Irritant Contact Dermatitis. Welcome to this detailed lecture on irritant contact dermatitis, or ICD, a condition that accounts for the majority of all contact dermatitis cases. Imagine this: a patient presents with redness, scaling, and burning sensations on their hands after frequent exposure to soaps or detergents. This is the essence of ICD, a non-immunologic inflammatory skin condition caused by direct damage to the skin barrier. It primarily affects individuals exposed to irritants in their daily lives, making it a condition we encounter often in clinical practice. Unlike allergic contact dermatitis, which involves an immune response, ICD is a direct cytotoxic reaction. It's prevalent. It's impactful, and understanding it is key to helping our patients regain comfort and functionality. Etiology. Now, let's explore the why of ICD. This condition arises from direct physical or chemical damage to the skin barrier, leading to inflammation. Here are the main culprits: chemical irritants. Everyday substances like acids, alkalis, solvents, detergents, and oxidizing agents can disrupt the epidermis, leading to irritation. Physical irritants, mechanical friction, pressure, and environmental extremes, such as extreme temperatures or humidity, exacerbate skin damage. Occupational exposure. Think of healthcare workers washing their hands frequently, food industry employees dealing with wet work, or cleaners exposed to chemicals. These professions are at higher risk. Individual susceptibility. Patients with conditions like atopic dermatitis or a genetic predisposition often have compromised skin barriers, increasing their vulnerability to irritants. History. Gathering a detailed history is critical when evaluating ICD. Onset. Symptoms typically develop gradually, directly correlating with exposure to an irritant. Symptoms. Patients often describe burning, stinging, and itching sensations in the affected area. Exposure history. Ask about occupational and domestic activities, as well as exposure to personal care products or industrial chemicals. Temporal relationship. Establish the timing between exposure and symptom onset. Immediate reactions are characteristic of strong irritants, while weaker irritants cause a cumulative effect. Previous episodes. Patients may report recurrent or persistent symptoms with repeated exposure. Clinical findings. The presentation of ICD varies based on the irritant's potency and exposure duration. Let's break it down. Acute ICD, erythema, redness at the site of exposure; edema, swelling caused by localized inflammation; vesiculation, formation of blisters in severe cases; desquamation, peeling or shedding of the skin; chronic ICD, lichenification, thickened and hardened skin; fissuring, painful cracks, especially in flexural areas; hyperkeratosis, excessive scaling and callus formation; distribution. Lesions are typically confined to areas directly exposed to the irritant, such as the hands, forearms, and face. Diagnosis. Diagnosing ICD involves a combination of clinical evaluation and investigative techniques. Clinical evaluation. The diagnosis is often straightforward, based on the morphology and distribution of lesions and the patient's history of irritant exposure. Patch testing. While primarily used to diagnose allergic contact dermatitis, patch testing can help rule out allergic causes in suspected ICD cases. Skin biopsy. Histopathology reveals features such as spongiosis, epidermal necrosis, and mixed inflammatory infiltrates. This helps differentiate ICD from other dermatoses. Management. Managing ICD effectively requires a three-pronged approach: avoidance of irritants, symptomatic relief, and long-term skin barrier restoration. Avoidance of irritants, identification. Work with the patient to identify and document specific irritants. Substitution. Recommend alternatives that are less harmful to the skin. Protective measures. Encourage the use of gloves, barrier creams, and protective clothing to minimize exposure. Skin care. Emollients. Use moisturizers containing ceramides or urea to repair and maintain the skin barrier. Gentle cleansing. Replace harsh soaps with mild, fragrance-free cleansers. Overwashing should be discouraged. Topical therapies. Corticosteroids. Low-potency steroids such as hydrocortisone 1% can be applied twice daily for mild cases. high-potency steroids like clobetasol propionate 0.05% are used for severe inflammation but should be limited to short-term use. Calcineurin inhibitors, tacrolimus 0.1% ointment is an excellent steroid-sparing alternative, particularly for long-term use on sensitive areas. Systemic therapies, for severe or refractory cases, corticosteroids, prednisone at 0.5 to 1 mg/kg/day, tapered over 2 to 4 weeks, may be required for acute exacerbations. Antihistamines, cetirizine 10 mg once daily or hydroxyzine 25 mg at night can help control pruritus. Treatment algorithm, mild ICD. Start with avoidance of irritants, emollients, and low-potency topical steroids. Moderate ICD, use mid to high-potency topical steroids and consider adjunctive calcineurin inhibitors. Severe or chronic ICD, introduce systemic corticosteroids for acute flares and phototherapy, such as narrowband UVB, for chronic cases. Conclusion: irritant contact dermatitis is a condition that is both common and preventable. Our goal as dermatologists is to identify irritants, alleviate symptoms, and empower patients with knowledge to prevent recurrence. Through education, targeted therapy, and individualized care, we can help patients restore not only their skin health but also their confidence and quality of life. Thank you for joining me on this comprehensive exploration of ICD.